Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on bronchiectasis under the section of respiratory medicine. So what is bronchiectasis? It's characterized by permanent dilatation of the bronchi, and it's due to a variety of causes, which we will be covering in a couple of slides. However, it's important to mention that in approximately more than 50% of cases, there is no cause found. As far as its etiology is concerned, really the biggest risk factor for it is the recurrent bacterial colonization and infection of the lung that leads to the activation of neutrophils and T lymphocytes and monocyte-driven cytokines that result to progressive airway injury. And as a consequence of this, there is a release of inflammatory mediators and elastase, which will then subsequently lead to inflammation and destruction of the elastic and muscular parts of the bronchial walls. And unfortunately, as a result of that, the patient will get permanent bronchial wall dilatation. So this is quite a thorough list or a table of all the causes that could lead to bronchiectasis and some of the examples of this. This is really quite important for the cases of PACES especially, because it's one of the conditions that patients, when they don't have a flare, they're actually really quite stable, and therefore making them suitable candidates to be brought for PACES examination. As you can imagine, it's quite a good question that the examiner can ask you as part of your viva to come up with a list, and you should definitely be able to list these options pretty thoroughly. So beginning with post-infectious causes, and these include tuberculosis, common respiratory childhood infections, and non-tuberculosis mycobacteria. The second cause is obstruction, and this includes a foreign body, a lymph node, or, for instance, a tumor compressing. Third one is congenital causes, and that includes alpha-1 antitrypsin deficiency. Fourth one is immunodeficiencies, such as HIV and hypogammaglobulinemia. One is over-response of immunology, and that's the case that you see in post-lung transplantation, as well as allergic bronchopulmonary aspergillosis, or ABPA for short. Sixth one is a mucociliary clearance problems, and that includes cystic fibrosis, Cartagena syndrome, and Young syndrome. The other causes that are also common as far as bronchiectasis is concerned include GORD and other autoimmune disorders, such as rheumatoid arthritis, Sjögren syndrome, sarcoidosis, systemic lupus erythematosus, Ehlers-Danlos syndrome, Marfan syndrome, ulcerative colitis, and yellow nail syndrome. And as mentioned earlier, about 50% of cases, we don't actually find any cause. As far as the signs and symptoms of bronchiectasis is concerned, really they are quite non-specific, and they include shortness of breath, cough, recurrent pleuritic chest pain, wheeze, coarse crackles, finger clubbing, and signs that are consistent with underlying pathologies such as rheumatoid. However, one of the key features that is particularly important for PACES is that as part of your history or your examination, you will realize that the patient is complaining of significant amount of sputum production every single day. And sometimes in PACES, the examiners might put a sputum pot next to the bed to sort of hint you towards a diagnosis that they do want you to be thinking about a condition that is quite prone to making quite significant amount of sputum on a daily basis for the patients. The investigations of bronchiectasis really depends on your history examination investigations and observations. Obviously, you would be wanting to take a thorough history and examine the patient, especially to pick up any clues that could lead you towards the underlying diagnosis. Your bedside observations, as you recall, we always stress on having a systematic approach in when you're answering the questions. So your bedside observations are going to be calculating your NEWS score, and if the patient, for instance, needs supplementary oxygen, then making sure that you supply that for them. Then you would move on to your blood tests, and these include your immunoglobulins, your autoantibodies such as rheumatoid factor, ANA, and ANCA. Electrolytes, including calcium, especially if you're thinking about, for instance, sarcoidosis as the underlying cause. Full blood count, including eosinophil count, if you're thinking about ABPA. And inflammatory markers such as CRP and ESR, if you're thinking about other connective tissue diseases. You may want to, depending on the situation or the case, you may want to consider a sodium concentration if you're worried about cystic fibrosis. You would do an arterial blood gas, especially if the patient is hypoxic. And you would, of course, move on to do a sputum culture, because remember, the key is to exclude infection in these patients, and obviously having a sputum sample and culture will help you target your antibiotic treatment. As for its investigation, really is surrounding three main categories. First one is a chest x-ray. You're partly doing this to make sure that you're not mistaken this cause for another respiratory problem, such as pneumonia or effusion. And in a case of bronchiectasis, the chest x-ray is not always abnormal. However, especially in case of an advanced bronchiectasis, you might be able to see some tram lines, which are the parallel thickened lines representing dilated, thickened bronchial walls. Or you might see some crowding of the bronchial marking. And the other thing that is quite textbook specific is the finger in glove appearance, which is resulting from the impacted central bronchi. The diagnostic modality of choice really is high-resolution CT scan of the chest, and it is certainly indicated if the chest X-ray is normal. The classic finding for bronchiectasis on a HRCT is the appearance of signet ring, which is due to enlarged bronchus and neighboring vessels. And then finally, you might consider doing a bronchoscopy, and that's mostly to look for or exclude any foreign body or endobronchial lesions such as a massive lymph node or carcinoma. As for its management, like any other chronic disease in the UK, the management is going to be through the means of multidisciplinary or MDT approach. Very frequently, these patients are referred to chest physiotherapists, and that's mostly for them to get some breathing exercises to help with postural drainage, and that needs to be done at least twice a day. They may be considered for antibiotics for repeated symptomatic infection, ideally after getting a sputum culture, and they may have bronchodilators, especially if there is a concomitant evidence of obstructive airway disease such as COPD or asthma. Some patients will be given prophylactic antibiotic, and that's mostly to cover for Pseudomonas. And bronchoscopy, as mentioned earlier, is mostly to exclude foreign body or mucus or tumor. And sometimes it can be used as part of the management for recurrent mucus extraction, especially if the patient has failed physiotherapy. In some centers, although quite rare, patients can be considered for bronchial artery embolization, and that's mostly for symptomatic management of severe hemoptysis. And it would be really important that the underlying cause that is triggering the bronchiectasis is optimized to maximum. The complications of bronchiectasis, really the biggest one is the recurrent infections and pneumonias. Sometimes patients can suffer from hemoptysis, which quite rarely can result to massive blood loss. In those cases, you would be recommending for an arterial embolization. And finally, again, quite rarely, some patient might develop secondary amyloidosis. Okay, so let's do some questions. Question 1. A 50-year-old lady presents with a 3-month history of worsening breathlessness on ambulation associated with a productive cough of clear sputum. She has a history of recurrent childhood bacterial infections and rheumatoid arthritis since the age of 25. On examination, the IMT2 doctor notes evidence of articular changes consistent with long-standing rheumatoid arthritis and an early inspiratory coarse crackles on auscultation of the chest. Given the likely diagnosis, which of the following is correct? And the options are A, small cell lung carcinoma is the most likely. B, rheumatoid arthritis is not a risk factor for her condition. C, her chest x-ray will definitely be abnormal. D, signet rings may be present on HRCT. And E, double lung transplantation is indicated. So if we go through these one by one, hopefully the history has been hinting and suggestive enough for you to be thinking about bronchiectasis, because this is a middle-aged lady who's presenting with breathlessness and productive cough of clear sputum. And she has got risk factors of rheumatoid arthritis and recurrent childhood bacterial infection to have the condition. And more importantly, the IMT2 doctor has picked up signs and symptoms consistent with bronchiectasis. So really the question is supposed to be testing your knowledge on bronchiectasis. So therefore, automatically option A is going to be incorrect because small cell lung cancer is not the most likely cause. There is no other risk factor such as smoking, for instance, that has been mentioned in the vignette. If you want a refresher of small cell lung cancer, please click here, in which we have discussed in depth the manifestations and presentation and management of small cell lung cancer. Option B is going to be incorrect because we know that autoimmune conditions such as rheumatoid arthritis is going to be a risk factor for bronchiectasis. Option C is her chest x-ray will definitely be abnormal. Hopefully by now you have realized that usually if there is the option of definitely in an MRCP question, is most likely going to be incorrect because, as most of you will know, medicine is not black and white really, and is most of the time in the gray zone. So having definitely is going to be incorrect most of the time. And in her case, this is also incorrect because she could have abnormal chest x-ray. However, we know that in bronchiectasis, especially in earlier stages, the chest x-ray is very frequently normal. Signet rings may be present on HRCT. That is the correct option. And that's in fact the classic signs or radiological finding on HRCTs in the case of bronchiectasis. And then finally, double lung transplantation is indicated, which is incorrect in here because the first thing that's going to be indicated is excluding an infection. And then second thing is going to be all the management options that we discussed earlier. And double lung transplantation is certainly not something that you would be considering as a first line therapy. Question 2. Which of the following is not a radiological feature consistent with a diagnosis of bronchiectasis on either chest x-ray or HRCT? A. Tramlines representing thickened bronchial walls. B. Signet rings generated by enlarged bronchus. C. Ring opacities. D. Finger and glove appearance from impact central bronchi. E. Honeycombing. And if you remember, we have just discussed that signet rings are the classic finding in HRCT. So option B is going to be correct. And options A, C, and D are the options that can be found on chest x-ray finding on the cases of bronchiectasis. And bear in mind, chest x-ray, as we discussed earlier, could be normal. So it will leave you with option E, which is honeycombing, which is frequently seen as a CT scan finding on the case of pulmonary fibrosis, not bronchiectasis. If you like a refresher on pulmonary fibrosis, please click here. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.